I'll be giving the first half of today's EM Controversies lecture. Today, I'll be arguing for the side of rhythm control in patients with acute onset Afib less than 48 hours. I want to thank Dr. D'Souza and Dr. Allen a lot for helping me with this lecture because God knows I needed some direction. So it took a while for us to focus on this specific patient population, but I'll explain a little bit later as to why I think that this patient population is going to be the one where I think ED providers can have the most impact. So before I go into the details of the lecture, I just want to briefly highlight why I think we should all care about this as ED providers. So in the hospital, that's about 1 to 2% of the US population. In addition to that, Afib costs a lot of money. So I think this figure is from back in 2016 or 2017, but Afib cost about $26 billion in healthcare expenditures. And most of that was from hospitalizations. So as ED physicians, I think it would make sense for us to try and find a way in the ER to both control quality of, or try to help improve quality of life for these patients, as well as decrease healthcare expenditures. So I want to argue that early cardioversion in acute onset Afib might be a way for us to accomplish those goals. So I think these are the reasons why you should pay attention. So Chris Anderson, get on your phone, okay? So just to rehash this case a little bit. Oh, so sorry. Robbie was supposed to introduce the lecture a little bit, but just for time constraints, I'm going to introduce the case. So we have a 55-year-old male, history of hypertension. He presents to the ER with 5 hours after the onset of palpitations. The patient's tachycardia 135, otherwise has normal vital signs. And let's say for completion's sake, we get an EKG and the patient's in Afib with rapid ventricular response. So I want you to keep this kind of patient in mind when Smriti and I are arguing our points. So just a little bit of background. Today is not going to be a comprehensive overview of the pathophysiology of Afib because that would take a lot of time, longer than a 15-minute lecture. But just the basics, I think we all know that Afib is a supraventricular arrhythmia that involves multiple ectopic foci in the atria that eventually leads to irregular ventricular response. Over time, that process then causes both atrial and ventricular dysfunction and causes structural and electrical changes in the heart. These processes all together then cause some pretty significant comorbidities for these patients. They can cause increased risk of stroke and systemic embolism, increased risk of cardiomyopathy, of heart failure, eventually hemodynamic compromise, and then eventually a higher risk of cardiovascular death. And in addition to that, as these processes take hold over time, it becomes harder to convert these patients back into sinus rhythm. There's a commonly used adage that atrial fibrillation begets atrial fibrillation. So the longer that these patients are out of sinus rhythm, the more consistent that Afib becomes, it becomes harder to get these patients back into sinus rhythm. So it would be within our best interest to cardiovert these patients as early as possible. So all the benefits of converting back to sinus rhythm are basically the reverse of all those significant comorbidities you might experience. It's been shown that early cardioversion is more likely to restore sinus rhythm. Stroke risk is proportional to AF burden or AF persistence. So the earlier we can get these patients back into sinus rhythm, it's possible that we can reduce their stroke risk, we can improve their cardiac function, improve their quality of life, and then also improve the symptoms that they have in Afib. And on top of all of that, there have already been many studies that show that cardioversion, both electrically and chemically, is safe and effective for this patient population. So very briefly, I want to go over the guidelines that we currently have for ED cardioversion. This is a consensus statement from the American Heart Association, the American College of Cardiology, as well as the Heart Rhythm Society. And it was recently updated last year. So if you receive a patient in the ER and they have Afib onset with less than 48 hours, as long as you appropriately anticoagulate them prior to cardioversion, as well as post-cardioversion, then the recommendation actually is to cardiovert them within those 48 hours. However, after 48 hours, then it sort of leaves the jurisdiction of the ER. Post 48 hours, there's a pretty significant increase in risk of stroke and systemic embolism. So the recommendation at that point is to anticoagulate these patients for at least 3 weeks pre-cardioversion, and then at least 4 weeks post-cardioversion. So I just want to highlight that the main reason why I want to focus on these patients with Afib onset less than 48 hours is because post 48 hours, it's sort of out of our purview now. These are going to be the patients who are going to be followed up by their primary care doctor and by their cardiologist several weeks post their visit in the ER. So we want to focus on those patients who have onset less than 48 hours. So unfortunately, there aren't actually that many studies that compare rate and rhythm control in this specific patient population. The J-Rhythm study was a Japanese study that was done back in 2009. It is a multi-center randomized comparison trial of rhythm and rate control in patients with paroxysmal Afib. For the purpose of this study, paroxysmal Afib was defined as Afib that was expected to convert to sinus rhythm within 48 hours of onset. So it's more or less the population that we're trying to focus on here. Patients were randomized to either rhythm control and rate control, and I have a list here of the most common antiarrhythmics that were used, the most common one being here fluocinolone in the rhythm control group. And then for rate control, they were also subjected to different rate control medications. But the most common medication that was used in this study was beta blockers. So the primary endpoint of this study was pretty interesting to me. It was a composite endpoint, and it included mortality and morbidities such as stroke, heart failure, serious bleeding. But one of the things that they included in the composite endpoint was how often patients change their treatment strategy, and I'll clarify that a little bit. Basically, patients in either intervention arm were allowed to switch over to the other intervention arm. So patients in the rhythm control group could go to the rate control group for their self-reported reasons, and patients from the rate control group could go to the rhythm control group for self-reported reasons. And that becomes very important when I explain the results of the primary endpoint later in a couple of slides. The secondary endpoint for the study was quality of life scores. So they assessed 3 different things: frequency of symptoms, severity of symptoms, and anxiety of symptoms. Now, before I go into the discussion about the endpoints, I want to bring this up. So this wasn't an endpoint in and of itself, but I think it's important to highlight. Patients in the rhythm control group maintain sinus rhythm at a higher rate over their follow-up period, which is 3 years, when compared to the rate control group here in the bottom. So this is a table that highlights the primary endpoint of this study. It was shown that more patients in the rate control group achieved the primary endpoint than the rhythm control group, and it was statistically significant with the p-value over there. But when looking a little bit closer at the data, what you realize is that the difference in the primary endpoint wasn't due to differences in morbidity or mortality, really. What contributed mostly to the difference in the primary endpoint was that alteration of treatment strategy, that changeover in treatment strategy. So if you look over here in the rate control group, much higher number of patients changed over to the rhythm control group as compared to vice versa. The most cited reason that patients changed over from the rate control group to the rhythm control group was because they felt that they had quote unquote uncontrollable symptoms. Now, patients in the rhythm control group also changed over to the rate control group, but it happened at a much lesser rate. And the most commonly cited reason was because they had some concerns over the side effects of the antiarrhythmics that they were receiving. It wasn't necessarily that they actually were experiencing side effects, is that they were sort of informed about the side effects and they preferred to go to the rate control group instead. But again, I want to highlight that patients more so switched over to the rate control group from the rate control group to the rhythm control group because they felt that their symptoms were not adequately controlled. And regarding the secondary endpoint of this study, when they were giving these quality of life scores, rhythm control patients gave better scores regarding the frequency of symptoms. When they were asked about the severity of symptoms and the anxiety of symptoms, they scored just about the same in both rhythm control and rate control groups. So really what I think you should infer from this study potentially is that rate control may not be as effective in control of symptoms as rhythm control. And there's a potential for rhythm control to lead to an improved quality of life for these patients. So regardless of the lack of literature within this patient population, a lot of providers are still pretty hesitant to use ED cardioversion in the ER. I think that stems from literature that states that there's no change in morbidity and mortality when rate controlling patients or rhythm controlling patients. However, what I want you to know is that most of these studies are based on populations that don't have to do with this study population. We care about patients who have onset less than 48 hours in the ER. Most of these kinds of studies compare patients who have either persistent AF or long-term AF. One of the most commonly cited studies is the Affirm study. So this was a 2002 study. It was a multi-center randomized comparison of rate and rhythm control in patients with atrial fibrillation. But most of this study population was persistent AF. The primary endpoint was overall mortality, and then the secondary endpoint was death, as well as the comorbidities that I've listed over here. So this study did show that there wasn't any statistically significant difference in morbidity and mortality when patients were either rhythm controlled or rate controlled. However, again, I want to emphasize that this study and many other studies did not study the specific patient population we care about. So I assume the rate control side will bring up some of these studies, but I want you to keep that in mind and see if it's appropriate for the study population that we care about. And then just a little bit of criticism of this study, since it is a landmark study that's often cited as an argument against rhythm control in the ER. This is a study that was done before CHADS-VASc was actually used for risk stratification in terms of systemic embolism and need for anticoagulation. So back when this study was done, on the rhythm control side, patients who were able to maintain sinus rhythm at 4 weeks were not anticoagulated. It could be that if this study was performed now in this day and age, when we subject all patients to CHADS-VASc, that those same patients would have been anticoagulated, and thus that group may have experienced a decrease in morbidity and mortality. However, that's just postulation, but I want that to be something you keep in mind when somebody cites this study as an argument against rhythm control in the ER. And then finally, I want to emphasize that there are studies that are still looking for certain outcomes in this patient population that we care about. One of the studies that was recently done was the ACWAS study, which is the acute cardioversion versus the wait-and-see approach study. It was done in 2019. It was a study done in the Netherlands, and it was, again, a multi-center randomized comparison of early versus late cardioversion with patients who had Afib onset less than 36 hours. Now, the primary endpoint of the study is not something that I want to emphasize really, because all it looked for was maintenance of sinus rhythm at 4 weeks. But again, that's not really an outcome that we care about. These are the outcomes that we care about. So in about 1 year, these are the outcomes that they're going to report. And some of these include AF recurrence, ED visits and hospitalizations, patient-reported experience measures, and total healthcare expenditures. So hopefully sometime this year, these outcomes will be published, and somebody, maybe Dr. Souza, will disseminate all these outcomes for us. But I want you to look out for these kinds of studies within this specific patient population. So, short lecture. I'm not going to add much more, but these are the points that I really want to emphasize here. That, again, persistent AF can cause really deleterious effects with potential to affect multiple organ systems. So it would be within our best interest, as well as within the patient's best interest, to cardiovert these patients as soon as possible, as it could reduce stroke rate and potentially improve quality of life. It's been shown multiple times that electrical and chemical cardioversion are safe and effective within this patient population, and especially with patients who are at low risk. But finally, the most important thing that you should take away from both my lecture and from Sruti's lecture is that there aren't enough studies that really compare rate control and rhythm control within this patient population. We only have a few of those kinds of studies. So I think what's really important is to have a shared decision-making process with patients. Some studies, or many studies, have actually shown that converting back to sinus rhythm does improve quality of life and could improve symptoms. So when you see this patient in the ER, you need to have an informed discussion with patients and let them know about the potential downsides of rate and rhythm control, the potential benefits of rate and rhythm control. And for me, at least personally, I would advocate for rhythm control within this population, just because I think that it could do better. And then finally, I just want to make a point not to listen to any of the people who are going to be talking next. Eden looks like a serial killer. Shruti looks like she's looking at Roche's face all the time. And there's no embarrassing pictures of Roche because she just has a million publications on Google, so you should maybe listen to her. And these are my references, and then we'll save questions till the end of the lecture.
Thanks,
Okay, we're going to hold discussion until after we do the rate control part of the debate. So we'll just have Smriti.
Hey everybody, I'm Smriti. I'm one of the fourth years. Thank you for listening to Brian. All right, so I'm going to be making the case for rate control. Here are learning objectives. First, we'll define the case for rate control. The other one is to discuss considerations for choosing your strategy, whether you're going to do rate or rhythm. And the third objective is the most important of all. If you didn't take anything else away from this lecture, clearly we are better than Brian and I. So this is just a reminder of our case. It's basically a stable patient without a documented history of Afib who's now presenting with Afib within 48 hours of onset. So whether to prioritize rate or rhythm control in Afib is not a new debate. It's been going on for the last 2 decades. And there have been multiple RCTs that have been large prospective and retrospective studies done on the subject. And all of them showed that rate control is not actually inferior to rhythm control, and rhythm control is not superior to rate control, even though I did just say I'm better than Brian. But there is a strong case for rate control over rhythm control when you're taking into consideration certain things like adverse effects, comorbidities, hospitalization, cost effectiveness, and so on. We're going to talk about some of those things. All right. So your first factor to consider when you're choosing a treatment strategy for your patients is not to choose something that can have potential harm for the patient. And rhythm control has both electrical and chemical options. And with more options come more adverse effects to consider before you choose your strategy. So first, electrical cardioversion. So it's pretty simple. Is in order to convert a stable patient electronically, you're going to end up causing them some pain, which in itself is an adverse effect. To reduce the pain, you have to sedate them, and then you're now exposing them to adverse effects of conscious sedation medications, which is a lecture in itself. But then you also have to wait for your patient to metabolize that sedative, and that lengthens your dispo time. Remember that many patients may not want to be shocked, and if you want to do rhythm control, you also have to consider adverse effects and toxicities of the different available agents. And even after you've made that choice, it's possible that it won't work. So whichever agent works, you may have to try a few different doses, you may have to try a few different medications, and then you're exposing your patient to adverse drug reactions from the different doses or the combination of the different meds that you're going to try for them. And some of these are pretty well documented. You know, they're not insignificant. There's QT prolongation, ventricular dysrhythmias, pulmonary complications, thyroid dysregulation, also orchitis, which is a thing, and you know, if you compare this to rate control medications, their ADRs are very well described. They're easy to control. You don't need sedation to control rate, and so you've automatically decreased your chances of exposing somebody to sedative medications to 0. And then another factor you want to consider when choosing therapy, especially in our patient population, is the effect of these meds when you have patients with renal dysfunction or hepatic dysfunction. In renal and hepatic dysfunction, your rhythm control meds now have a very narrow safety margin. Earlier, Dr. Wiener was talking about cardiac toxicities, and essentially you're going to have you're more likely to have a toxicity of a drug at a smaller dose because they're not able to clear anything. So in terms of the iatrogenic harm that rhythm control has caused in the literature, I think the most significant one was hospitalizations. There's a wide range of the frequency of hospitalizations being higher than rate control, 10 to 52% higher. However, there's pretty good consensus among all of these RCTs that hospitalization admissions are always higher in rhythm control groups. Even when you control for hospitalizations that are just for the hospital protocol, so you have to admit somebody for X amount of time after you cardiovert them, or you need to get those 2 6-hour EKGs for Desai. Even when you control for those, the number of hospitalizations just because of rhythm control are higher than in rate control groups. In terms of mortality, there were 2 studies that I found, Affirm as well as as KIAC. There were both about 5% total mortality in rhythm control or rate control, but as Brian talked about earlier, these studies they didn't really take into consideration patients less than 48 hours presentation, so you can take that one with a grain of salt. And then the other thing, probably the most significant, is severe adverse effects. All these medications have documented side effects like VTAC, Afib. There have also been some cases of MIs, rare cardiac arrest, pacemaker implantation because they couldn't convert back to sinus rhythm, and as well as strong embolism. So we talked about, doing rhythm control within 48 hours for patients because that's when you have the most effective conversion. That's what Brian was saying. But the thing is that how do we accurately assess onset of symptoms? Are patients actually reliable at telling you when their Afib starts? Because they can sense that they're tachycardic. They can sense the weakness and syncope, shortness of breath, palpitations. But even then, it's not always accurate. How many times have we had patients just present with, I don't feel very good, and then you get their EKG and they're in Afib or RER? Can they really feel an irregular heartbeat when they're not tachycardic? So can they truly feel the actual onset of atrial fibrillation? So this paper here was a 2015 prospective cohort study of Aphid symptoms and outcomes in stable patients. They monitored 460 patients with continuous EKGs for a week, and then they had their answers questions about their perception of having an irregular heartbeat and how long their episodes were. Overall, they actually found that 15% of patients were completely inaccurate about their AF burden, out of which 67% completely underestimated how long they had been in Afib or whether they had been in Afib at all. This paper actually makes a case for the fact that patients are not reliable in describing the onset of their arrhythmia. They can semi-reliably tell you when they're in rapid ventricular response, but as for how long they've been in Afib, you can't really take them at their face value. The other thing to consider is you have patients who have dementia or baseline for quality of life, and they may not know when their symptoms started as well. This other 2015 study looked into clinical correlates and outcomes of asymptomatic Afib. This one, they actually enrolled 3,000 patients from a registry that spanned 9 countries, and they followed up with them at a little over a year. The study found that 40% of patients overall were asymptomatic at some point, either during the study or before the study. And overall, 17% of all patients were fully asymptomatic at all times. This is a significant finding given that the study actually spans multiple countries. It's not just one geographic region, and it's over 200 patients as well. So essentially what this implies is you cannot be 100% sure that your patient has truly been in Afib for less than 48 hours, which means that there's a chance that they already have a thrombus. And the theory behind cardioverting these patients in less than 48 hours and not more than that is because you want to make sure that you're not dislodging that thrombus. However, how can you be sure if you don't know if they've actually been in Afib for 48 hours? And the only way for you to really be sure is to get a TEE on every single person that comes in, which isn't always practical. And then another important factor to consider when choosing between rate and rhythm control is, does your patient actually need rhythm control? A few studies in the last decade have shown that patients often spontaneously convert to sinus rhythm even within 48 hours. This paper here is a landmark study. It came out last April in 2019, and it's directly relevant to our case. They randomized 427 stable patients with new less than 36-hour onset of Afib, just like our guy, so that half of them only got rate control / the wait-and-see approach, because rate control technically isn't converting them to sinus rhythm. And then the other half got early cardioversion. The rate control group got delayed cardioversion only if they did not convert back at all within 48 hours. So they found that at the end of 4 weeks, 91% of the rate control group had spontaneously gone back to sinus rhythm without any sort of rhythm control at all. And 94% of patients in the early cardioversion group were in sinus rhythm. So the difference was only 3%, it's very small. Even more significantly, they found that 69% of the rate control group spontaneously went back to sinus rhythm within 48 hours. You didn't even need to do the delayed cardioversion with them. The recurrence of Afib, of them going from sinus back into Afib, was 30% in the rate control and 29% in the rhythm control, so even that was not a significant difference at all. So the point is that if there's no difference in their recurrence rate, if they're going to spontaneously convert on their own within 48 hours anyway, and there's a high chance of that, why do you want to expose your patient to pharmacologic rhythm control drugs that can cause other adverse effects, or electrically cardioverse them and expose them to pain and sedation and all those things? The other study that also touched on this a little bit was the STAP trial. It did not find any benefit to rhythm control at all. And they also found a crossover rate that I'm going to go into in the next slide. Many of these major RCTs have not actually shown benefit with rhythm control over rate control, particularly in patients with high risk of arrhythmia recurrence. It's like the STAFF, the AFCHF, and the Affirm trial. The Affirm trial that Brian also touched on earlier found that Afib is poorly responsive to rhythm control drugs. And this is not just from their data, it's also from the literature review that they did for their own paper. For example, so the other, and another point towards that is that 30% of the patients in the rhythm control arm in Affirm crossed over to the rate control arm, whereas only 14% patients crossed over from the rate control to the rhythm control arm. But out of that 14%, 35% went right back to rate control. And the primary reasons for switching from rate to rhythm were failure to maintain time to rhythm and inability to tolerate adverse effects. And those are really the two primary points that I think are in favor of rate control over rhythm control in less than 48-hour Afib. This is also in keeping with other trials. The AFCHF trial had 21% of the rhythm control group switch to the rate control, whereas only 10% switched from rate to rhythm, and that was because of worsening CHF. And then finally, to make this other point, is that the Annals of EM also published a lit review in 2011 that covered 5 big studies, and they concluded that overall there's a relapse rate of 3 to 17% in rhythm control as well. So if you're going to do early cardioversion in your patients, you need to make sure that they're aware that they might actually go back into Afib. One of the challenges of managing Afib is balancing the risk of bleeding and the need for anticoagulation. And both AHA and J-stage guidelines give recommendations to give anticoagulation based upon stroke risk regardless of subtype Afib. Brian actually did touch on this as well, that a lot of these studies were done when before CHAS-VASc was being used more frequently. But a lot of the old literature that is a proponent for rhythm control focuses on the bleeding risk in rate control. However, you should be anticoagulating patients who have a high CHAS-VASc score regardless of your treatment strategy. Finally, so you want to think about what is easier to manage. First, you have your discharge considerations. With rate control patients, you can start them on anticoagulation, start them on a beta blocker or a calcium channel blocker, and discharge them. You can have them follow up with cardiology within a month or so, and it's easy for us to prescribe and titrate those meds as well. But if you have rhythm control, when you give them rhythm control, you may have to hospitalize them based on what your hospital's protocol is. You may also have to give them urgent cardiology follow-up, and that may not always be possible for our population particularly. The other thing is that rhythm control does fail quite often, and per the Affirm trial, for example, the rhythm control success rates were pretty low. And what happens when they fail? When they fail rhythm control, they get admitted. And so now that's another discharge consideration for you to have your patient may not want to stay in the hospital just because you chose rhythm control for them. The other thing is your ED flow consideration. If you've got your CCT room is blowing up and you have a bunch of unstable patients and you have this one person in Afib with RVR, it may be very easy to control their rate. It's not that difficult to get their tachycardia under control, but you may have a hard time maintaining their sinus rhythm. You may cardioversion, it won't work. You'll try another medication, you'll try a different dose, and whereas you can control their rate and then move on to your other patients for sticker. And the last thing is your own personal comfort and familiarity with these meds. Some of us may be more comfortable with rate control medications than rhythm control medications as well, because we know what their adverse effects are, we know how to titrate them, their dosing is really easy. And then since we are in the US, we can't really debate treatment strategies without talking about costs. Your cost of medication, you want to consider, because can your patients actually afford what you're prescribing to them? You may want to start them on Dofetilide or Eubutilide or something like that, and it's not, are they going to actually be able to afford something like that? The other thing is also the cost of hospitalization, even in terms of ED. If you're going to try to control their rhythm and you fail, or if your hospital has a protocol, you're going to hospitalize them, and then you're spending a lot of money on their disposition. Many of these rate versus rhythm trials also did cost analyses comparing the two treatment arms, and rate control was unanimously cheaper by anywhere from $2,000 to $10,000, depending on the endpoint that was measured. My last point is that there is guideline support for rate control over rhythm control. For example, the NICE guidelines, they recommend that for symptomatic paroxysmal Afib, your first choice of treatment should be a beta blocker. And then in selected patients with recurrent paroxysmal Afib, the out-of-hospital initiation of antiarrhythmics can be possible. But even then, that's a little bit controversial, and it's better to, and they do recommend rate control. These other guidelines from AHA, they solidify the argument that you don't know how long a patient has been in Afib, and they say basically that for a newly discovered Afib, you don't do anything but anticoagulate PRN. Or if they're persistently in Afib for more than 7 days, then control their rate, anticoagulate them, and then consider rhythm control on antiarrhythmics if it still doesn't work. If we assume that this patient is wrong about this being a new onset Afib and it is actually recurrent paroxysms, then anticoagulation and rate control is actually recommended first. And this is in keeping with that earlier paper I spoke about, comparing early cardioversion versus delayed cardioversion. So how do you choose a strategy? Overall, if a strategy to control rhythm could guarantee to be efficacious, cost-effective, have no risk of adverse effects, there would be no argument. Rhythm control would be better. However, this is really the case. Rhythm control is difficult to achieve and initially and sometimes requires the use of potentially toxic drugs. If your objective is to first do no harm, then rate control is more important. The reason to do rate control is for less adverse effects, avoid your sedation and pain, reduce hospitalization and costs, and also be able to manage your patients more confidently if you're more comfortable with rate control. And every RCT and meta-analysis also showed that overall rate control is not inferior to rhythm control. And you know, the takeaway from this lecture really is that there's no one-size-fits-all strategy. You have to take into account all these other things, like what's the underlying cause of Afib, their age, their comorbidities, what the patient prefers. Do they want to stay in the hospital after getting cardioverted? Do they want to, are they okay with getting the sedation and getting electrical cardioversion and possibly going home, but possibly also staying back? What are their socioeconomic considerations? Do they need to go home right away today? Like, are they going to be able to stay in the hospital for longer? Also, what is their access to a cardiologist? Do they have somebody that follows them and they can quickly call them and go into clinic sometime this week? Or are you going to have to go through the hospital system and get them to see the patient in one? And lastly, your physician can comfort. Big thank you to Eden and Roshnak for their help with this lecture. This was our first debate lecture, so we definitely needed all the help we could get, and just these are all of our answers.
I think Smriti wins based off of presentation name and slide design.